Good evening and welcome to our webinar on occupational therapy for tic disorders. My name is Angela Sullivan, CDC Program Coordinator, and I will be your moderator this evening. This webinar is being provided as part of the Tourette Health and Education Program, a program of the Tourette Association of America in partnership with the CDC. During the webinar, we would be very happy to hear from you and include your voice in the conversation. You are encouraged to ask questions and share your comments using the question panel on the right side of your GoToWebinar player at any time. We will collect your questions and address them during the Q&A session at the end of the presentation. Funding for this webinar has been made possible by our cooperative agreement with the U.S. Centers for Disease Control and Prevention. The views expressed by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. It is my pleasure to introduce you to our speakers this evening, Dr. Heather Simpson and Dr. Tana Carson. Dr. Heather Simpson is an occupational therapist, adjunct lecturer at the University of Florida and UF Health in Gainesville, and serves as the coordinator for the Tourette Association Southeast Regional Centers of Excellence. Although she has a pediatric specialty from the American Occupational Therapy Association, she treats both adults and children with tic and Tourette disorders. Dr. Simpson is an expert in occupational therapy management for tic disorders, as well as use of CBIT in the Southeast area. Dr. Simpson has been allotted opportunities for advocacy and training to occupational therapists, as well as other allied health professionals and management of tic disorders, including a chapter in 10 Secrets to a Happier Life with Tourette Syndrome. Dr. Tana Carson is an occupational therapist and adjunct assistant research professor at the University of Florida and UF Health in Gainesville. Dr. Carson is certified in the Comprehensive Behavior Intervention for Tics and works with children with tic and Tourette disorders. Clinically, Dr. Carson has expertise in occupational therapy management for autism, sensory processing disorders, anxiety, vestibular rehabilitation, and tic disorders. Academically, she has participated in multiple research studies in the field of sensory processing and autism and is currently conducting clinical pilot studies using exposure and response prevention to reduce auditory sensory over-responsivity. Without further ado, Heather and Tana, please go ahead with your presentation.
Hi, I'm Tana Carson. Thank you for having us today. So we'll start with the title, Occupational Therapy and Tic Disorders, More Than Sensory. So we titled it this way because we want to tell you more about occupational therapy and what we can do for those with tics and Tourette's. Beyond the common perception that we are only focused on sensory, we'd like to share with you what else we can do as occupational therapists. So these are just some disclosures telling you that Heather is associated with the Tourette Association and that the images that we used in this presentation have been cited. So the objectives for this talk are that we would like for you to understand the role of occupational therapy in serving those with tics and Tourette's. We describe the role of OT in managing tic and Tourette disorders, briefly review strategies often used by OTs to meet the complex needs of those living with tics and Tourette's, and to promote occupation and living productive, fulfilling lives. We'll also introduce how to locate OTs and how to advocate for OT services across the lifespan. So we'll start with what is occupational therapy. If you have been wondering that, and that's why you came to this talk, you're not alone. People often assume the word occupation means getting a job, but actually it means any meaningful activity that occupies your time. So that takes different forms, from young children learning how to sense their environment and react adequately, to playing, to social skills, to performing well in school. And it extends all the way into adulthood, being able to take care of yourself, being able to manage finances. So just to clear up some misconceptions, occupation actually means meaningful activities that occupy your time. So now that you know this, you'll be well equipped if somebody asks you, or if you have to ask on behalf of your family member and advocate for them to receive OT services, you can explain a little bit more about what we do in our scope of practice. So OT is primarily focused on independence with those activities. And we focus on those activities across the lifespan with a primary emphasis on living life to its fullest and achieving your goals. So in any aspect of any factors of your life, making sure that you're equipped to do those things.
All right, so we're going to go ahead and get started with probably something that you've heard about as occupational therapists in the TIC world is the use of CBIT. And we're going to go through this very, very quickly. How did OT get involved in the comprehensive behavioral intervention for tics? So we do know in the early 2000s, the JAMA, the Journal of the very famous medical magazine, came out and showed that CBIT is shown effectiveness for the as the main behavioral therapy for tics and Tourette's. And now the Tourette Association recognizes that CBIT is the gold standard for this therapy. So occupational therapy providers have said, hey, well, listen, we want to jump in on that. We don't really have a great way to manage that. We're not learning that in school and how to manage tics and Tourette's. So why can't we jump in? So Dr. Jan Rao, Dr. Leon Durr, and the team there at University of Alabama in Birmingham and their Center of Excellence program came up and started to do a research project that looked at that. And they particularly also looked at the occupational performance within that comprehensive program. And what they found was a significant reduction in the number of tics and function-based limitation with the use of comprehensive behavioral intervention for tics. So since that, we have noticed that with the UAB program, I've gotten trained at UF, and since then we've gotten a much bigger, vastly growing occupational therapy program that has started to grow nationally. Dr. Jan Rao and with the Tourette Association has started to really advocate for getting occupational therapists trained, because we are actually it's working very well with our practice framework, and it seems to be a perfect fit for us in collaborating with the interdisciplinary team. The American Occupational Therapy Association, who is our governing body within our profession, has recognized the efficacy of this program. And in fact, we have done a podcast to promote it to other occupational therapists. The Tourette Association, along with members on our CBIT board, have presented it at national conferences, and we're starting to present it at schools. So now occupational therapists coming out of school are ideally not going to be dumb to tic disorders, and they're going to know what tics are coming out of school. And there are more research projects now coming out for occupational therapists, as you heard a couple of them being mentioned in our introduction. So it just in 2013 was really when it really, 2010, 2013 is really when it started to become prevalent for us as occupational therapists, but it's coming on heavy and it's coming on strong. The core components of CBIT really align with our practice framework. And what I really wanted to emphasize with this is the psychoeducation, the competing response training, the managing the external environment, and the function-based interventions is really big, and it matches right within our automatic practice framework. It's stuff that we've already been doing. We just didn't have a good mechanism and a good guideline to do it. So the program that the Doug Woods and his team had come up with the CBIT has really guided our program, and once we've been certified on using the CBIT program. The ultimate goal of the CBIT is to educate and enable the patient and the family to identify and implement a competing response, analyze the environment, implement modifications, and ultimately, along with our practice framework, independently manage any new tics that when they're in a waxing or waning phase and when they come up down the road. So now that you can go and look online on many of the CBIT talks that you can find on the Tourette Association website, I want to talk to you more about what else can we do for you besides sensory. So do occupational therapists have to be trained to treat tics and Tourette disorders? So to do CBIT, they do have to get the training, but otherwise, no, we don't. We can This comes right out of our typical practice in school, right? So why is that? Well, what we know is that Tourette's, the tics, the motor tics, the vocal tics are the primary dysfunction of the disorder. But really, the peer relations, the academic problems are the secondary issues. And what's really interesting is that the occupational issues, so the school, the dressing, the social issues, are preventable limitations that come along with Tourette's that occupational therapists, manage. And so that's where we can come along. So we do know that it can be difficult to find well-trained therapists who know how to manage the disorder. And the great part about occupational therapists is that we, occupational therapists, are found in schools. We are found in rehab facilities. We're found in hospitals, and we are found in home. So there is a lot. We are high access to care if you can get an occupational therapist on board, even if they're not well aware of tic and Tourette's. It's just educating them on the whole background of Tourette syndrome itself. So how is that? So on the left of your screen here, you'll see our occupational therapy practice framework. It's really our domain. It's a nice, kind of confusing diagram, but what it shows here is the many different occupations that we can do. And on the right is the Tourette syndrome iceberg, which I just love so much. And what you'll see here is we address occupation, which you'll see on the right, handwriting. That's hidden underneath that pyramid or the iceberg. And then executive functioning issues. We've got social participation, which is right there on that iceberg. ADLs, and we've got leisure activities, which is sensory, the ability to go to movies and it's too loud. Learning disabilities, rest and sleep issues are right there on that iceberg. So a lot of our domains within our actual practice framework are right there on that iceberg. So it's like we're meant to be. And this is just a different version of that. And you can find this chart that is in the Living with Tics, the Educator's Guideline on how occupational therapy can actually help those living with tic disorders. And we're going to break apart many of these. So these are 4 factors: the occupations, performance patterns, client factors, and context and environments that really go into our occupational therapy interventions. And this is what every occupational therapist utilizes when we come up with our treatments. So the first one I really want to talk to you about is occupations, those things that occupy our times. And what we do know is that research shows that our activities of daily living, such as dressing, rest, sleep, education, play, all worsen during a waxing period with tics. So we know that those activities do become difficult when tics are at their worst. So one of those examples is in school. So education. Dysgraphia is a big issue, and we are doing a study between 3 of our centers in the Southeast right now to look at this dysgraphia. But dysgraphia is a difficulty with handwriting and less words, but essentially it's this, there's many components with it, and we're finding that many kids and adults with tics have difficulty with handwriting. And there's many components to it. So just saying that dysgraphia is bad handwriting is under qualifying why this is an issue, because there could be impaired postural control, there's fatigue, hand cramping, the OCD of just right feeling that is needed, the rereading over letters, ocular motor difficulties, staying on the line, having to go back and reread letters, losing your place. Mild visual motor deficits have been found, and tics that can occur with handwriting. So having to go back, having to flip over your pen, having to rewrite the letters can all be interfering with handwriting. And if schools are not aware and looking at that just right feeling or having to rewrite or re-erase, then that can create difficulties with school. And what has been shown that 75% of kids and adults have experienced difficulties with handwriting during a waxing time period. So that's quite a bit. So if you're not getting assessed during a waxing time period, when the tics are really bad, then we're not doing you justice to assessing the handwriting. We also know that schoolwork becomes more difficult due to the tics, and that's due to mental fatigue, having to pay attention to the urges, maybe having negative response from staff or from peers. Maybe they're not aware of what the sounds are like or what the motions are. Difficulty managing emotions, whether it's from the mental fatigue, difficulty with frustration of what you're having to deal with, difficulty of paying attention to your tics while the teacher's talking, difficulty with concentrating, and then what we know is difficulty with homework, exams, handwriting, anxiety, you name it. These are proven difficulties in school, and occupational therapists being in school can help eliminate some of these difficulties. So what I was mentioning, occupational therapists in school, they are important providers within the education support team. They support a student's ability to participate in desired daily activities with their roles. Their ultimate goal is to aid learning and through promotion of positive behaviors while teaching adaptive skills that are needed for academic success. So they're not helping with home activities, but really more the academic success, whether that's organization, learning, note-taking, etc. They assist in school-based interventions to improve knowledge of Tourette's of peers and teachers, so they can help the class better understand what tics and Tourette's is. So when you feel lost sometimes at school, getting an occupational therapist on board is very helpful. So self-care. It has been shown that some children with tics and Tourette disorders have difficulty with planning and initiating routines. And unless one's given to them, then things such as creating a morning or nighttime routine is difficult. And occupational therapists help with that. And on the right, you'll see an example of a nightly routine that I created with one of my patients that I've worked with. And this was her setup, but this is something that we use to help her have a checklist through the night. We also talk about managing appropriate hygiene, remembering to put on deodorant, but also not taking 30 minutes in the bathroom to use the toilet, or maybe not doing 30 minutes to do your toothbrushing routine. And then toileting. We knew enuresis is a big issue. Delayed toilet training has been shown to be an issue with those with tics and Tourette's. Toothbrushing, maybe sensitivity, and those kids who fight you with toothbrushing, those are all within our scope of practice within occupational therapy. Another thing is dressing skills. So if you feel like your child or adults, but mostly children, have difficulties with fine motor skills of dressing, so buttons, tying shoes, they just can't grasp it. Those are all things within our scope of practice as an occupation that we are well versed and have many strategies on learning how to handle and modify. The other thing is when clothing feels weird, textures, tags, I got to keep pulling on it. I can't wear underwear. I can't wear shirts, can't wear pants. Occupational therapists address that. Another occupation is sleep dysfunction. So many of us struggle with sleep at night, and I'm not sure if you all are aware of how many hours of sleep we're all supposed to be getting at night. But teenagers are supposed to be getting 8 to 10 hours of sleep at night. And studies show that only 15% of typical age teens are getting that appropriate amount of sleep. Now, if you add in tics, that's much less. Children ages 9 are supposed to be getting 9 to 11 hours of sleep at night, and adults 7 to 9 hours of sleep. Studies show at least as little as 1 less hour of sleep at night affects emotional regulation. So if they're getting any less sleep than that, then it's more likely that they're going to have rage, fatigue, more anxiety, more mental frustration, more difficulty with school the next day. And so it's really important that we can help manage that. So one of the things that we talk about is the ABCs of sleeping. There's a great article out there called the ABCs of sleeping, and we address those by any one of these 9 steps. So age-appropriate bedtimes, consistency, schedules and routines, location, getting your child to sleep on their own so that they're not in your bedroom, exercise, an appropriate diet, no electronics in the bedroom or before bed, which might be a battle within itself. Positivity, making the bedtime routine good for you and good for your child as well. Independence with falling asleep, having the needs of the child met, and then having all of those equal that great sleep. This is one of my favorite books, What to Do When You Dread Your Bed. It teaches children how to do magic tricks when they're having difficulties falling asleep at night, and it's a great book. But that's just one of the strategies we do for sleep.
So in regards to social and pragmatic skills, children with Tourette's are more likely to have difficulties with peer interactions. So both building or maintaining relationships, possibly difficulties with peer attachment, making friends, lower levels of social functioning, and all of the above impacts peer relations, as well as bullying, social rejection, and stigmatization. So some kids have reported that they feel like there's a stigma against them, and that people often associate Tourette syndrome with the coprolalia that you often see in movies. But actually, in actuality, only 8 to 10% of people with Tourette's have coprolalia. So many kids with TS feel misunderstood and can be victims of bullying. OTs can work to address social skills and social cognition through individual and group treatments, as well as or social groups. So we address a variety of needs in this domain, including making and keeping friends, appropriate conversations, handling conflict, building relationships, maintaining relationships, understanding and interpreting perceptions of others and others' feelings, and then how to address bullying, how to respond to bullying in a healthy way. And then one of the goals is to decrease the stigma of Tourette's in multiple contexts, to really build these kids up, build up their confidence, help them to feel more independent with being able to explain what Tourette's is and what they need when they need it. So on the right, you see this picture for social behavior mapping. This is just one of the techniques that OTs have at their fingertips for doing this. And basically, it helps to improve kids' insight as to how their behavior is perceived by others and what the consequences of that behavior are, and to help them think through what they could do differently and how they could do things differently to get the goal that they to get to the response that they actually want, and that's more in line with their values. This is another fun game, just a couple of examples of what we can do in some of these individual or group treatment sessions. So we use a lot of fun games, we use we play out scenarios, and it's a safe place for kids to practice and discuss these things that are challenging for them.
All right. So driving, I know that can be a scary thought for teenagers, but also for adults, right? So driving is an occupation. It's a very important thing. We want people to be independent, and we want to move forward, and want them to go on and be successful adults. But how do we get there? Occupational therapists specialize in driving, and there's certified driving rehab specialists who manage this, but also occupational therapists who aren't certified in this can help manage that. We do this by making sure the strength and range of motion that is needed to drive is appropriate. We look at the cognition, so the ability to have the appropriate attention and problem-solving skills is appropriate. That vision is doable, that you have the visual attention, that you can do visual scanning, arousal management, that the impulse control, stress management, and regulating sensory input, that you can drive and pay attention to the road and not get frustrated that someone's coming into your road, or can you pull onto the highway and someone's not going to hit you? Are you able to judge that? And you'll see here there's an example of a pre-driving screening. Is your teen thinking of driving? There's actually a proven correlation, teens need to have life skills before they can actually go to driving. And we don't think about that a lot, but do they get enough sleep? Do they know how to handle emergencies? Can they do a lot of doing their own clothes? Do they know how to handle their car maintenance? If they don't, then we should not be talking about driving first. And occupational therapists address all of those things. Do they know how to manage money? Right? Do you want to teach a 14-year-old that? Yes, we do. And that's where occupational therapists come involved. And then you'll see an occupational therapist actually developed this app here on your lower left of your screen, and it actually trains visual attention and problem solving with driving. So we do that by modification even of vehicles. So if something is not physically possible, then we can modify the car, provide training, and if they're not able to drive, then how do we seek alternate sources of community transportation? And then once we're working, we value we do actually help you with your job. So we can be occupational therapists. We do actually help with maximizing strengths in a workforce. We do want you to be successful where you want to be successful. We want to adapt the work environment to meet the needs. We want to identify barriers to getting work and participating in the work, whether that's driving there, whether it's finding a job you like. Utilize healthy behaviors. We want to enhance your work performance. So if you can't have the attention sitting out in a lobby, then can we move you off to the side to make sure that that's less distracting for you and your tics aren't as bad? And can we maximize success to live a productive life? So we're going to talk about some client factors because we know tic severity can impact your functional levels. So the first one that we're going to talk about is executive functioning, and there's a couple of really good webinars on executive functioning with tics and Tourette's, so you can look those up on the Tourette Association website. But we do know that executive dysfunction and executive functioning are the self-regulatory behaviors necessary to select and sustain actions and guide behavior within the context of goals or rules. So when that becomes impaired, that creates difficulty with organization, making decisions, problem solving, time management, so knowing how long to plan out before your task is due at school. So if you've got a project due in 2 weeks, do you wait the day before to do it? Difficulty with inhibition, difficulty with working memory, and difficulty with arousal and emotional regulation. So what about, is that the rage attacks, right? So what rage, emotional regulation, crying out of nowhere. We know that these are difficult areas for those with tics, and so we help address those. And these are just examples of that. So there's the Work Smart Academic Planner, which helps with that planning ahead. Time Timer app. There's a hamburger paragraph that helps break down that working memory when you're writing papers. And then one of my favorites, this is actually something I use, is the hanging shelves, because I don't like to close my drawer, so it's one extra step of working through it. And that's what we do, is we keep things simple to help kids with executive functioning issues.
So when we think about sensory processing, at the most basic level, sensory processing can be described as simply a stimulus coming into the nervous system and through the sensory receptors, and the nervous system producing an appropriate response, such as actions, thoughts, behaviors, emotions. So those are the output. It's a little bit more complicated than that, but that's just at the very basic level. Sensory modulation disorder occurs when the central nervous system has difficulty regulating the processing that occurs in the nervous system between the stimulus and the response. Typically, sensory modulation produces a behavior or an emotional response that is relative to the intensity and the nature of the sensory input. However, when there's a sensory modulation disorder, the response doesn't necessarily match the level of the stimulus. It may be over-responding or under-responding. So as you can see in this table here, this is what has been proposed as the nosology or the taxonomy of sensory processing disorders. And so the ones that we're referring to today in this talk are under the sensory modulation disorder, looking at sensory over-responsivity, sensory under-responsivity, and sensory seeking. There's also a really great talk that Heather Simpson has done for the Tourette's Association that's on YouTube, and it's titled Sensory Integration for Tics and Tourette's. That goes more in depth into this topic, but we're going to just kind of provide the basics today. So as OTs, we consider sensory differences in every domain. So typically we think of the 5 senses, but there are actually more than that. Often vestibular and proprioception are overlooked. What we know about sensory processing in tics and Tourette's is that it tends to lean more towards the sensory over-responsiveness side, and that's been shown in all of the sensory domains. So it tends to be more the repetitive, constant stimuli, faint stimuli, external stimuli, both unconscious and conscious input, and particularly in the tactile domain. So aversion to types of fabrics, different textures in the collars of clothing, where clothing is on the body, and wet, sticky textures can be difficult for these kids to tolerate. They tend to prefer intense sensory input in the tactile domain, especially, like, for example, deep proprioceptive input, muscle belly squeezes, heavy work, and that can be very regulating. There is a difference that I want to distinguish between sensitivity and responsiveness or reactivity. So one study has actually shown that adults with Tourette syndrome do not actually show an atypical ability to detect tactile stimuli. Rather, they report difficulties tolerating the stimuli. Sensory over-responsiveness paired with OCD, ADHD, we know that the more comorbidities there are, the more severe symptomatic behaviors there will be, increased anxiety, and greater functional limitations. Parents have also reported that sensory processing disorder is predictive or related to difficulties in activities of daily living during tic waxing periods, so when tics worsen. So taking all of this into consideration, OTs are very well versed in addressing and analyzing sensory needs and coming up with strategies to help improve these kids' or adults' ability to tolerate these stimuli more easily. When we think about premonitory urges in OT, they're not yet well understood neurologically. It's been proposed to consider premonitory urges under 3 categories: sensory, cognitive, and autonomic. OTs can address, OTs are really helpful for assessing the type of premonitory urge and how to best address it. So it can be important, in addition to using a competing response, it may be important to address other factors of premonitory urges, such as body mechanics, sensory awareness, postural training, muscular imbalance or weaknesses, strengthening if needed, and addressing anxiety and self-regulation in addition to others. So OTs can help with evaluating sensory processing, addressing arousal anxiety, and help to modify the behaviors. We know that difficulties with sensory processing are linked to arousal and anxiety as well as unwanted behaviors, and OTs can help you navigate those relationships. Okay, oops, sorry. So the mechanisms underpinning tic exacerbation in response to overstimulation are still elusive, but they're likely to reflect an information overload related to sensory gating deficits. So what do we mean by overload or overstimulation? So this is too much information, too much sensory stimuli, overexcitement, anticipation, watching TV, playing something that's really exciting or fun, video games, multitasking. Alternatively, there can be difficulty with too little stimulation. So low environmental stimulation is also likely to distort information processing, possibly by shifting the attentive focus towards interoceptive stimuli and the pursuit of alternative goals. So when you think about when you're bored, when you're understimulated, if you're in a really quiet environment, you might start to feel sleepy, or if you're trying to fall asleep at night, everything else kind of fades away and the focus and attention can be shifted to sorry, I'm laughing at the video, to interoceptive stimuli and result in an increase in that premonitory urge and the increase in tics. So when we think about self-regulation support for the sensory difficulties, we kind of follow 3 phases basically in addressing the arousal regulation side. So the first step is to improve self-awareness of arousal levels and responses to sensory input. The second phase, once that's been mastered, is to identify strategies for modifying the arousal level. And for each individual, these strategies might be different. What works for one person might not work for another person. So it really takes some guidance and some help navigating that process. The third phase is utilizing strategies in real time to modulate arousal level and or unwanted behaviors. We use several techniques to do this. These are just a few examples. The alert program, zones of regulation, and a frustration beaker. Prevention is the key. So that first phase of the insight, really being able to identify your arousal level in the heat of the moment is really key. And for parents, identifying the triggers and the cues that your kid is reaching their limit.
Right. So we're going to hurry through this next part because we have a lot to share with you. But the relaxation training has been shown. This is used in CBIT, but relaxation also has been shown to help decrease tics. And this is stuff that occupational therapists can do without being CBIT trained. So whether it's progressive muscle relaxation, diaphragmatic breathing, motor imagery, all this has been shown to help reduce tics, not as effectively as CBIT or a standard therapy, but it used quite nicely in occupational therapy. Also, yoga has been shown to decrease anxiety, which we know worsens tics. It can improve sleep, improve postural control, motor planning. Exercise has also been shown to improve sleep. Short bouts, even short bouts of exercise have been shown to decrease tic severity, not necessarily right afterwards, but it has a standing effect. And also it decreases pain associated with tics. Occupational therapists are great at introducing yoga and exercise. And then Qigong. Qigong has had a strong correlation and connection with self-regulation and tactile sensory hypersensitivity, and in addition, helps with parent and caregiver stress. So all of those together have been shown, these stress management programs with mindfulness have decreased the secondary effect of managing tics. So they're not directly correlated to tic management, but together, occupational therapists can use this to help manage tics and as an adjunct therapy.
So when we think about the neuromusculoskeletal and movement-related functions, we often think about pain. So kids with tics and Tourette's can experience pain from these chronic movements or associated with the premonitory urges, right? So OTs can assist with this pain experience by setting functional goals and training with the use of neuromuscular reeducation, pacing, or energy conservation strategies, creating home programs that help with reducing pain, as well as joint protection strategies and proactive pain control. So again, recognizing the context and situations that might elicit pain, and actively coming up with plans how to strategize for that. So when this is utilized in conjunction with physical therapy, the biomechanical approach can improve function and pain. We really emphasize a collaborative, interdisciplinary approach to make sure that we're addressing all of the puzzle pieces that are associated with Tourette. Additionally, under this domain falls sensory and behavior. So sensory and behavior are intertwined. It's important to be able to differentiate and parse them out, and that can often be really challenging for families and for patients. So understanding the causes of unwanted behaviors is really important, but you may need some help teasing that out. OTs can conduct assessments to further analyze the child's response to sensory stimuli, as well as the context and provide specific solutions. So it's important not to make assumptions. For example, high sensory craving with sensory over-responsiveness can lead to increased aggression, hyperactivity, and anxiety. And it's important to parse out what's sensory and what's behavior. So down at the bottom right is a nice workbook to help teachers, parents, therapists tease that out. So OTs can help parse these things out.
And that workbook is available, that assessment is available on the Tourette Association website.
Mm-hmm.
So one of the things we do know is that structure is very important for those with tics, as well as anything else, right? Anxiety, ADHD, but chaos has been shown to have an effect on tics. So occupational therapists, we love structure, we love charts, we love routines, and so we are wonderful at creating picture charts, regular charts, and virtual charts. We create charts. We love charts. So we emphasize charts all over the place, structure. And that includes for those living with tics, but also the families. And we know that it decreases stress. It decreases the anticipation of the unknown, right? That anxiety that comes with it. It improves transitions. It also improves that executive functioning and planning difficulties that comes along with it. So we do really emphasize understanding and managing the environment and context. And this includes environmental modifications, not only for those living with tics, but families.
So if you're familiar with CBIT, you're familiar probably with this functional assessment, right? It's based on antecedents or triggers and consequences that may reinforce tics, as well as broken down into 2-factor categories on the left-hand side. So you have internal and external stimuli. This table can be really helpful for thinking through what's the context, what's promoting tics, what's reinforcing and maintaining tics. And I think every therapist you're going to see, whether they're from psychology, psychiatry, social work, OT, speech, is going to use this technique. But I think OTs are particularly well versed in thinking through the really minute and detailed sensory factors, both internal and external, in the environment in this context.
All right, and then we promote the tic management lifestyle. So we understand that family emotional regulation is important. We know that the families have high burden and stress. So we know that it affects the whole family, and we want to make sure that we manage the stress within the family, whether it's for you, for the kids, for the tics, for the sensory concerns, and not only that they affect the kid or the adults with the tics, but also the fact that it's a spouse, the parents, and how that the family emotion will impact those living with tics. And then we also we OTs love assistive technology, and assistive technology is any item, piece of equipment, product, system commercially available or modified or created that increases, maintains, or improves functional capacity of those living with any disability. And so what we do is, if we can't modify it on our own, if we can't figure out a strategy using your body to manage the tics or coming up with strategies to increase your success, then we're going to certainly try to figure out another way to make you independent. So it might be something like this Snap type app that is above on your top left, that is, you take a picture of a worksheet and you type in the answers. Or it could be the rocket pen on the right that helps so that you don't have to hold on the pen because that triggers the certain tic. Or it could be an ergonomic gooseneck clip so that your head isn't in a position that triggers the tic. Or it could be a voice recording pen so that when instead of having to write, when that dysgraphia comes on, you can press a button and it records the teacher's lectures for you. So that's just 4 examples of some simple adaptive equipment, but there's many, many more out there. So in summary, those are just some brief examples of the occupations, performance patterns, client factors, and contexts that all come into play in our occupational therapy interventions. So you might ask, how do you get plugged in? Where can I get occupational therapy? It might sound a little bit overwhelming and a little bit weird. So we work in a lot of different places: hospitals, healthcare facilities, schools, clinics, community centers, home health, even skilled nursing facilities. So the biggest thing you need to do if you want occupational therapy is to ask your physician about a referral for occupational therapy. And I would make sure you write a diagnosis of tics or Tourette's. And I would, when you go to your occupational therapist, you can bring a copy of our PowerPoint, which we'd be happy to give to you. And you can also give them our information, because sometimes they may not know all that's out there. But the Tourette Association has many good tools that can be shared with occupational therapists. The other thing is, if it's in school, talk to your child's teacher or guidance counselor about the need to get those occupational therapy services. Or you can find more at the Occupational Therapy, American Occupational Therapy Association, and that just lets you know about any occupational therapy provider, any licensed provider. You can also go to the Tourette.org website, and you can type in the find a doctor, look by your state, and then you can, anybody that has this OT, OTD, MOT, anything that has an OT, an OTA, we should have added that on there. OTA stands for Occupational Therapy Assistance, or a COTA. Any of those, anything that has an OT in there, pretty much is your occupational therapist. So I know that was a lot in a very short time period, but there's Tana's and I's contact information. And we would be happy to answer any questions now.
Thank you so much, Heather and Tana. We're now going to begin answering some of the questions that were submitted during tonight's presentation. As a reminder, you can still submit your questions through the questions pane on your control panel. If we're unable to get to everyone's questions, or if there are additional questions here at the Tourette Association, we have a full-time information referral staff who are available to help you if you email support@tourette.org or call 1-888-4-TOURETTE. So I see there are two questions here, Tana and Heather, or a couple are popping up now. So one person is asking if you guys could give a definition of paligraphia.
Yes, absolutely. So paligraphia, I used it as, and I'm sorry for not clarifying that. That is kind of a rewriting tic. So graphia just stands for writing, and paligraphia is the rewriting. So rewriting over a letter, let's say if you write the letter A and having to rewrite it over and over again. So it could be the repeating of it, it could be the rewriting of it.
Okay, great, thank you. So another question we have is, are there limitations to initiate OT on children?
Age limitations?
As far as typical occupational therapy, I would absolutely say no. Go for it.
We treat from birth to death. I mean, we treat the whole lifespan. But as far as some of the self-regulation strategies, for younger children, there might be more of an emphasis on parent education, parent support. For kids age 5 and up, I would say the self-regulation stuff can get a little deeper into really empowering them and educating them as well. So that might be like one age clarification just in how we address things, but really from the whole lifespan.
Okay, another question we have, are there any specific interventions that work better with teens?
The big thing that I find with teens, especially with tics, is finding ones that are meaningful for them. So I like to do assessments that are, and the big part about occupational therapy is finding things that are client-centered or patient-centered or person-centered. So in particular with teens, I like to make sure that I always do something that they want to do. Because if I come in and say, we want you to be learning how to do better in school, and that's the first thing I start with, then I don't always get them jumping on board. But if I say, listen, my goal is to get you more independent with the things you want to do, then I start with that. And then I can build on where I'm going and where we want to go based on that. And I think there are many, many different types of interventions, but I always start, especially with the tic population, on making sure I am doing a client-centered, making sure they have their own specific goal.
Okay, great.
And definitely arousal regulation would be the other one. So I always do arousal modulation.
Mm-hmm.
Okay, we have another question here. Tips for encouraging a very resistant middle school student in working on self-regulation, such as a zones program.
Can you repeat that one more time for me, please?
Sure. Do you have any tips for encouraging a very resistant middle school student in working on self-regulation, such as a zones program?
I think that goes back to Heather's comment about motivation.
Okay.
Yeah, so I always find I would like to find out why we're regulating them. So what is encouraging them? Why are they acting? So it might go back to that functional behavior assessment and try to figure out, is it arousal that's actually encouraging them to create that arousal dysregulation, or are there something else? Could they be acting out from arousal dysregulation, or could it be executive functioning issues causing mental fatigue that is causing arousal issues? So I might do something more I might back off a little bit and see kind of more of a person-centered assessment and see what's causing them to feel so heavy and creating difficulties.
I think there are two main factors there with what Heather's saying. One is motivation. And so you can do any therapist can do some motivational interviewing, find out, what makes them want to get better at regulation. Would they like to be able to sit through the day, or is that not important to them? There's got to be some component of their arousal level difficulties that they don't like and they would like to be better at or be able to do differently. And so that really can get at the motivation. And then the second part of that, what Heather was saying, was that really looking at the factors involved. So what's going on in the context? What are they experiencing? What happens before they're dysregulated or have changes in their arousal level? And then how are people or things changing after that happens?
Great, thank you. Okay, we have time for one more question. I know a bunch came in at the end here, so just as a heads up to everyone listening, I will have access to all these questions afterwards. And if you are still interested in getting the answer, or if you'd like us to reach out to you, please feel free to email the Tourette Association or email Heather and Tana, but we will definitely try and answer any questions that you do have. But as the last question I will give you guys is, what is the typical duration of CBIT? For example, would it be over the course of a couple months or a year?
So the standard program of CBIT is 1 time a week for 6 weeks, and then every other week for 2 weeks after that. So it's 8 sessions over 10 weeks. And then typically it is, there are booster sessions tagged on to that. So typically no more than 10 weeks. And then you can have maybe 1 time a month after that for a few months. It is a very short program, and there is a lot more information on the Tourette Association about the duration of the program and how long it's used and the frequency of the program available on the Tourette Association. And I'm happy to send you more information if you need it.
Okay, great. Thank you both again so much for a great presentation. This is unfortunately all the time we have for our webinar tonight. Once the webinar closes, you will all receive a survey on the presentation, and we would really appreciate it if you can complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with the link to view a recording of today's webinar. Additionally, the webinar will be posted on the Tourette Association YouTube channel for those who were unable to participate today. We encourage you to reach out to us on social media about this webinar or other ideas and suggestions you do have. On behalf of the Tourette Association, thank you again for joining us and taking the time to view our presentation.
Thank you.
Thanks for having us.